Hello everybody. A very warm welcome to this lunch session here organized by Nestlé. Thank you for being here and not being outside in the sunshine. Well, I can assure you we are in the panoramic room. I have a fantastic view, but you will also have a fantastic view on the speakers and the content of their presentations. So a warm welcome to this lunch meeting. Please join us. First of all, I would like to show my own disclosures. I am an intensivist, I'm a surgeon by background, and an expert in clinical nutrition. So I'm very happy to be joined here today by two excellent speakers that we have. And first of all, we have Professor Dr. van Zanten, who is very well known. He's a background internal medicine, which is always very good to be intensivist and internal medicine specialist. He is at the Wageningen University at the Netherlands, head of intensive care in the Gelderse Vallei Ede, and he will be talking about transition from one-size-fits-all to endotyping in critical care nutrition. So this endotyping will be very interesting. And also, he's one of the tallest speakers here in this symposium, so the one-size-fits-all. He's a big size. He's very well known, a lot of publications, and he will join us and talk us about this topic. But we are also very happy, and once again, thank you to Nestlé for organizing this and having the opportunity today to share with you our thoughts. We also have Professor Dr. Pierre Singer. In the world of nutrition, once again, a very well-known and renowned researcher, clinician, and speaker. And his background is now in the Herzliya Medical Center in Tel Aviv, and also in the Research Institute Rabin Medical Center in Israel. So we have two excellent speakers, and I am sure that they will live up to it. Professor Singer will be the second speaker on harnessing AI for tailored patient care in nutrition therapy. But we will first give the word to Professor van Zanten for the first lecture. The floor is yours.
Thank you very much, Elizabeth, for your kind introduction, and thanks to ISICEM and Nestlé Healthcare for inviting me to this session. And I would like to address a very, interesting topic. I feel it's very important, and I will try to bring you into the world of personalized nutrition, precision nutrition. And I understand that will be not very easy to do, but the way we perform nutrition therapy nowadays is maybe not the best for our patients. So to start with, this is a snapshot from the American nutrition guidelines. And they have been recently revised. And the first question is, should we give higher or lower energy intake to our ICU patients? And the answer is, well, it should be between 12 and 25 kcals per kg per day in the first 7 to 10 days of ICU stay. Now, I would like to challenge this recommendation. Should we give 25 kcals per kg to all our patients on every day of the first 7 to 10 days of ICU stay? I'm not sure about that. And what about, should we dose it based on our body weight? Now, what about proteins? They had a recommendation of 1.2 to 2.0 grams of proteins per day per kilograms of body weight. Should it be total body weight or another way of calculating the dose? And should it always be the same? So these are the questions that, led me to think about, are we doing the things we have to do? Now here you see my disclosures. I've given lectures to all nutrition companies, and I'm also the chair of the FREM sections, that ISICEM section on feeding, rehabilitation, endocrinology and metabolism. So very involved in the field of sepsis and nutrition. Now you've seen these publications over and over. So this is what we think should be the energy intake in the first 7 days of ICU stay. And when you do indirect calorimetry, you get a reading of resting energy expenditure based on the Weyer equation. And we know now that giving not the full 100% during the first week is probably in the best interest for the patient with respect to mortality outcome. So the optimum is maybe slightly hypocaloric, around 70 to 80% of the resting energy expenditure. And we know from others that have studied this based on the resting energy expenditure measurements that 10% overfeeding an individual patient, so when you go over 10% of their individual indirect calorimetry measurement, already leads to increased risk of morbidity and mortality. So overfeeding is not very good for our ICU patients, and there are many reasons for that. I've summarized a few of the consequences of early overfeeding in ICU patients. So we should prevent that. And when you give enteral nutrition, maybe the patient can do something about it. You can make GRV, gastric residual volume, you can make diarrhea or so, but with PN, there is a 100% bioavailability, so we have to be careful not to overdo this and not to give too much of the calories in the early days of critical illness. Now, there is one essential difference with you as healthy persons. You start eating now. Maybe you did skip breakfast and had your dinner last night. Then probably your stores were used to provide you energy during the morning. So glycogen breakdown for glucose, lipids were broken down to free fatty acids, the muscles for amino acids. So that's the normal catabolic response. Now you're eating. The moment your macronutrient levels in the blood go up, your glucose, your carbohydrate levels, you start producing insulin. And at the same time, you will block the breakdown of your body stores and you start building up. That's the normal anabolic response. It does not happen in ICU patients, at least not in the early phase of critical illness. So we have a lot of inhibitable endogenous energy production. It goes on while we give nutrition and insulin therapy, so the anabolic hormone. But many patients in the ICU in the early phase have insulin infusion while having high glucagon levels, so the catabolic hormone. So there are all catabolic processes going on. So what happens if you measure 1500 kcals by indirect calorimetry and you give the full dose on day one and you do not inhibit the endogenous production, the total of these two components will be too much for the patient. That's overfeeding. So then, of course, over time, this endogenous production will reduce and the effect of overfeeding will disappear. But now we believe we only can give maybe this small part of non-endogenous energy by exogenous feeding. So it should be built up over a few days until this endogenous production is very low. We don't know exactly at the bedside, that's a problem. But from studies we know it's probably there for a few days, and it can be real marked in the first day. It can be more than 1200 kcals per day. So this is our, idea how to build up. This is what we do. You can have another build-up schedule, but we do in steps of 25% until we meet the target around day 4. We use an equation at the start, but around day 3, 4, we use indirect calorimetry to have the next target for the patient. So we repeat this every 3 days. So every 3 days we have a new energy target for the patient. And during the first few days we also measure phosphate levels, because when there is a drop in phosphate levels, there could be refeeding hypophosphatemia, and you have to restrict the calories to a maximum of 500 kcals per day. And then you build up slowly afterwards. Of course, you also, when you prescribe nutrition, you have to take into account the non-nutritional calories from glucose, dextrose, from propofol or citrate, because that's also nutrition. It's non-protein nutrition, so you have to take care of that. When you reduce your tube feeding or parenteral nutrition, you will reduce also the protein intake. So maybe you have to use some protein supplements to meet the protein targets then. Now, we have learned that there are many equations, and all the equations are not that good. On a population levels, they are okay, because the average of many equations is almost the average of what we measure with resting energy expenditure devices. But the individual variation is huge. So some patients can be over 600 kcals higher or lower than the energy expenditure predicted by an equation. So I think that the equations are useless for ICU patients. Energy expenditure is very dynamic over the course of ICU stay. So this is one of the reasons that in the ASPEN guidelines we have recommended to use indirect calorimetry in all your ventilated ICU patients. And that's what we do every 3 days in our unit. If you don't have such a device, you can maybe use VCO2 from a mechanical ventilator times 8.2, or otherwise you have to rely on equations. But you know that is probably not very reliable, and then we recommend only to go for 70% of the equations to prevent overfeeding. And this is a paper of one of my PhD candidates, Hanneke Monen, showing that in the early phase of critical illness, energy expenditure can be slightly lower and it goes up over time. I come back to that. During the recovery, energy expenditure can be much higher, and it's dynamic also in individual patients. So you cannot use one single equation, one reading. Now let's move to the protein part of the nutrition. How can we use protein intake and know what's in the best of the interest of our patients? Now, older studies have shown that when we increase the protein dose in the nutrition, this was parenteral nutrition, increasing the dose from 1.1 gram per kg per day to 1.5, you see there is a mitigation of the muscle mass loss. So ICU patients have huge muscle mass loss. It was estimated to be over 1 kilogram per day in patients with multiple organ dysfunction syndrome. So you can see higher protein dose, maybe less muscle mass loss. And that's why many nutritionists and intensivists and dietitians are protein lovers. We need to give more proteins, and that's better for the patient. But we, some time ago, did this retrospective analysis of our database of patients in the ICU, and we found something interesting. So here you see the 6-month mortality on the y-axis and the days in the ICU on the x-axis. And we made 3 groups. So patients with a low protein intake, an intermediate intake on that specific day, or a high intake. Now you can see the green bars, the high intake, there's nobody in the first day. So it's non-achievable to get a very high protein intake on the first day. But you see on day 2 and 3, there was already some patient with a very high protein intake, but it was associated with a high mortality. And in the rest of the week, it seems to go down. And in the blue bars, you see the low protein intake. When it was low in the first few days, mortality was low, but when you kept on giving a low protein intake, the mortality seems to increase. So we mixed all the data again, and we made Kaplan-Meier survival curves. And in the lowest line, the blue line, you see the patients with a protein intake of less than 0.8 grams per kg per day all the time, on every day in the ICU. Now you see a slightly better survival in the patients with an intake over 0.8 grams per kg per day. That's the middle line. But the best group was low in the first 3 days, progressing to high in the second part of the week, suggesting that there is some kind of metabolic timing effect of the proteins. So maybe patients are not able to handle proteins the same on day 2 as compared to maybe day 7 or so. So this is one of the reasons maybe that also in the guidelines we have stated you should give at least 1.3 grams per kg of proteins. That's slightly higher than for normal. We have probably enough with 0.7, 0.8 grams per kg per day. And there's this word, can be delivered progressively. So maybe we also have to slightly increase the protein dose over a few days until we meet the target. And now it becomes a little bit more simple, but because when we also progress the proteins to the target gradually, we can use energy and protein in tube feeding or parenteral nutrition and just gradually increase the dose over a few days. And that's what we do now, a stepwise approach. Now, there have been published many studies, and we felt that the more proteins, the better the outcome. But now, after the publication of the EFFORT trial, and more studies are upcoming, the PRECISE trial we did in the Netherlands and Belgium, and the protein target trial in Australia. So at the end of the year, we know the answer, and we see here that my idea is that somewhere over 1.6, 1.7 grams per kg, there could also be induction of harm in some patients, maybe not in all. And maybe when you go very low, with a very low protein intake, there could also be an increased risk of mortality. So probably also for proteins there is a U-shaped curve. But we have to do more research to find out exactly where it is and what are the individual differences. Now, I have two male patients here with pneumosepsis in our ICU, weighing 100 kilogram, 180 meters height, and a BMI of 30.9. So how much proteins would you give to this patient? You can maybe use adjusted body weight, but let's make it simple. We use 1.3 times 100 kilogram, so 130 grams of proteins. Now what we do not target the proteins based on the total body weight any longer, because we believe when you dissect the body into its body components, and you can do that using BIA, bioelectrical impedance assessment, at the bedside with this kind of technique. And the lean body mass, or the fat-free mass, is bone, muscles, and organs, is not the fat mass. And we believe that proteins are not so necessary for the fat mass component. So then we have to target the proteins on the muscle mass, so the fat-free mass. And we tested this concept in COVID-19 patients. We did a lot of bioimpedance assessment there, but there's one problem with BIA. It sends an electrical stimulus through the body of a patient and it's measured. But when there is increased water or edema in the patients, this will be considered to be fat-free mass. So you get an overestimation of the muscle mass. But because of these devices use multi-frequency, we can measure the intracellular and the extracellular water, and there is a normal ratio of 0.38. So when this ratio is elevated, we know there is edema, and we can adjust for this factor. This is also done in dialysis patients to find the dry weight. So what is the optimal body weight for dialysis and removal of water? So this is what we do then. We adjust with this equation the BIA to a standard dry weight fat-free mass. And then we use this fat-free mass to calculate the protein needs. And when you use the fat-free mass, you cannot use 1.3, but then the same is about 1.85 grams per kg of fat-free mass. Okay? And then we adjust the ratio, and so these two males were measured. They had the same body weight on ICU admission. The actual body weight was different, 104, 102. And then we calculate this, and you can see that the adjusted fat-free mass, if you wish the muscle mass of the patient, there is almost a difference of 30 kilograms of muscles. So one patient is more sarcopenic obese, so a lot of fat, high body weight, and low muscle mass, and the other is very muscular. So probably we should give them a different protein dose. So now you see 150 COVID-19 patients, and you see, well, that the females have a lower lean body mass than the males. Is that a surprise to you? That males are more muscular? Probably you knew that, average, but many equations are exactly the same. So the protein dose for males and females, 1.3 grams per kg. Maybe we have to do that different. But also, these two males with a body weight of 100 kilogram, as you can see here, this one has a much lower lean body weight than this one. So based on the total body weight, you cannot predict the muscle mass. You know that. If we calculate now using 1.85 per kg per day for proteins, patient A is having an overdose of proteins of 30 grams, while the patient B is underdosed with 22 grams of proteins. And I think this is one of the problems of the studies addressing high versus low protein intake in ICU. We don't know actually the fat-free mass of the patients. We dose based on total body weight. So this is what I call phenotyping. We can better know what is the energy expenditure, we can better know what is the muscle mass, and then we can better predict what is the optimal dose. And that's what we do in the ICU. We do every day, every 3 days we do BIA and indirect calorimetry. We use the adjusted fat-free mass on ICU admission times 1.85 grams per kg per day for the protein dose, and we adjust the energy based on the indirect calorimetry over time. And I show you some preliminary data of a study we did. We have a large cohort of patients that were in the ICU for a long time. So you see 10 measurements. That means ICU stay of 30 days, every 3 days a measurement of BIA. And we separated the groups in 3 groups. When you had a protein adequacy based on this fat-free mass times 1.85, so their individual target was optimal, more than 90%, between 80 to 90, or lower than 80%, you see that the muscle mass loss was more profound in the patients that did not achieve this individual target. You may say, so what? When we do exactly the same analysis and we insert the total body weight times 1.3, any association is gone. So it suggests that we have probably to dose the proteins based on the individual protein muscle mass of the patients. And this is what I also have written in this editorial in Current Opinion. We have to move on to the next step, and that's endotyping. Because we had this effort trial, a very high protein trial, performed by Darren Hyland and co-workers, published in The Lancet, and they aimed for a very high protein intake. They achieved slightly lower, but still a huge separation between 0.9 in the standard group and 1.6 grams per kg per day in the high group. And actually there was no difference in the primary endpoint, but they saw increased risk of mortality in the patient with AKI, without dialysis, so with renal failure, and high SOFA scores, suggesting that these patients cannot handle the high protein dose. And then they did a post hoc analysis looking at the urea levels. So when you give a lot of proteins and they cannot be used for muscle protein synthesis in the muscles, they have to be abolished. So they will be metabolized to ammonia, to urea, and you find high urea levels in a way to remove your overdose of proteins. So urea could be some kind of biomarker. And what they found is that the negative effect of the high urea dose, of the negative effect of the high proteins given, was driven especially among those patients with a high UCR, with a high urea to creatinine ratio. So that suggests that maybe urea could be a biomarker of harm when you overdose proteins. And why could it be? Well, this is the cell. These are the mitochondria. We have mitochondrial dysfunction during critical illness. So the ATP production is reduced. And when there is an energy deficit in cells, the signaling to the nucleus of the cell will tell the nucleus, reduce protein production, because we have a lack of energy. So lack of energy, critical illness, is a proteostatic condition. Now, is it very helpful to give a lot of proteins then? Maybe not, because it cannot be utilized by metabolism, and then only urea production will be the result. And this is an example of one of our patients, was in the ICU for a very long time, 75 days, was on nutrition exactly 1.3 grams per kg per day after a build-up of 4 days. No gastric intestinal problem in this patient. It was a neurological problem. And you see in the upper part of the slide, you see the serum creatinine levels. And what you see is slightly declining creatinine over the time. This patient didn't have any renal failure. What is the reason? The loss of muscle mass over the time in the ICU. You see a slightly decrease in creatinine. But in the lower part, you see the urea-creatinine ratio, if you wish, because the creatinine is not that different. It's the course of urea over time. You see there are these increases in the blue curve. And every time we had an increase in CRP in red, first in admission, there was an infection. After some time, we saw a line sepsis, so a bloodstream infection. And at the end, we had a ventilator-associated pneumonia. And every time after this episode, we saw an increase in this UCR for 10 to 12 days, suggesting that metabolism changes according to the inflammatory status of the patient. And during this episode, the patient was not able to handle all the proteins for muscle protein synthesis. So maybe we can use this urea or UCR as a biomarker for metabolism. And then we have something for endotyping. Then we know what is the metabolic fate. And we know from work from Leanne Chappell and Imre Kau, one of my postdocs in Australia, that the absorption and digestion of whole proteins in the gut in ICU patients on day 4 is normal. So there's not really much malabsorption in ICU patients. But when there is an abundance of amino acids postprandial, there is a low incorporation of the amino acids into the muscle proteins. So there is anabolic resistance. It's not used. So you can give a lot, but it's not used. Now, to summarize my presentation, this is what we do now. I think the outside of this, I'm sorry, go back. The outside is one size fits all. Use just an equation. You give every day exactly the same, 20 kcals per kg per day, 1.3 grams of proteins. That's what most of us do. The next step could be measure indirect calorimetry and go for the energy expenditure of your individual patient. Maybe use BIA to calculate the muscle mass of the patient and dose the proteins according to their individual muscle mass. But the next step is to monitor the endotyping, the metabolic fate of the macronutrients we give. Can the patient handle the macronutrients we give to the patient? So then it becomes more complex and we need more biomarkers. Maybe that urea-creatinine ratio is one. Maybe a high insulin dose could be something for energy. Maybe a high RQ predicts overfeeding, but it's a challenge to know exactly what to do. And we have these phases. I published this paper with the chair of this session, Elisabeth de Waele and Paul Wischmeyer, because we believe also over time we have to increase the nutritional dose during the recovery, both for energy and for protein intake, because we need to repair our tissues and hopefully get some of the muscle mass loss back. Okay, I conclude. So I've showed you that we need to have a shift in approach from one size fits all to individualization, to precision nutrition therapy. We have to gradually progress in the early phase, but then we have to find out what is the optimum for this individual patient. And then we have to dose and time energy in proteins and micronutrients in a customized approach for optimal patient response. And we have to measure this response, but still very difficult at this moment. So the challenges in the individualization are, of course, the variability in the metabolic fate of the nutrients. We don't know exactly what will happen with what we give. And that will be the future. Maybe the next speaker can address this, whether AI or that kind of techniques can help with us. So we are on the quest of searching for the new biomarkers to help with this kind of strategy. And of course, we have to continue efforts in advancing nutrition therapy in critical illness. With that, I'd like to conclude and thank you for your attention.
Thank you. Thank you very much, Professor Van Zanten, for this excellent overview, a fantastic view on individualized protein approach. We are really taking knowledge and probably clinical practice to the next step. So thank you for this enlightening presentation.